Nursing care for the child in the healthcare setting. Nursing of infants and children is consistent with the general definition of nursing because nurses still look at the diagnosis and treatment of how children respond to actual and potential health issues. The attitude of personnel that the child comes into contact with is very important in pediatric nursing. There's different types of nursing that's provided. We have family-centered care, and we provide family-centered care because the family is the one constant in a child's life, and families are constantly growing and changing. When we deal with a child, we also need to take care of the family emotionally in addition to the child. Atraumatic care is the use of interventions that minimizes psychological and physical distress for the child. For example, when we're preparing children for procedures, make sure that you provide space for the parent in the room and do no harm. Case management has the primary responsibilities that include coordinating care and the care based on clinical practice guidelines. It has the benefits of improved child and family satisfaction, decreased fragmentation of care, the ability to describe and measure outcomes for a group of clients. In planning care for children, the nurse should realize that play is an important part of nursing care plan in accordance with the child's individual developmental level. Healthcare settings for pediatrics include the outpatient clinic. This can reduce emotional impact of illness because it eliminates or reduces the need for separation from family. We also provide care in the home or hospice in the home for acute and chronic conditions. Care at this point can be provided by the family with nurse supervision or by a nurse. Family may require respite care, however, when care is provided in the home. Support groups may also be available for the family. And we also provide care in the hospital. We do encourage parents to room in and provide staff consistency. This helps reduce stress and fear in the child. And a special room should be provided for unpleasant treatments or procedures so they don't associate unpleasantness with the room that they are assigned to. The role of the pediatric nurse is varied. The therapeutic relationship is provided as the nurse because you have to have a caring attitude with boundaries that will set you apart from the child and the family. We're family advocates. We need to educate families on services that are available, inform them of treatment and procedures, be involved in the child's care, encourage change or support existing healthcare practices or beliefs of the family. Disease prevention is done through education about hand hygiene, proper nutrition, immunizations, dental care, socialization, and discipline. Health promotion is done through education about ways to prevent injury and promote mental health. We provide support and counseling. Counseling involves a mutual exchange of ideas. We support the child and the family in their healthcare decisions. Realize, though, especially with adolescents, that you have to develop that trust relationship. Adolescents will be more likely to open up if you have that relationship. Coordination and collaboration. We collaborate with other healthcare team members, with family members, ancillary services. Nurses are the ones who coordinate nursing care with other activities of other departments. And research. We stay current on evidence-based practice articles and contribute to research whenever it's possible. When dealing with children, we need to be certain that we are getting appropriate signatures on consent forms. We need to ensure that whoever does sign the consent understands the purpose and the risks involved with the procedure or with the proposed treatment or procedure. We need to look at the age of majority and competence. In most states, the age of majority is 18, but we do have emancipated minors. So they are legally under the age of majority, but the law recognizes them as having the legal capacity of an adult. Some of these would include pregnancy, marriage, high school graduation, military service. Requirements for obtaining informed consent with children are the same for adults. Verbal consent may be obtained if the parent or guardian is not available if you use 2 witnesses. Eligibility for giving informed consent, we need to make sure it is the parent who has custody in a divorced home or the legal guardian. We can provide treatment without parental consent. Urgent medical or surgical care is required, and if the child is accompanied by the grandparent or a child care provider, then treatment can be provided. We can treat through consent by proxy or emergent situations, but we do need to document all attempts to contact the parent or parents. Adolescent consent and confidentiality. All states have enacted legislation to allow adolescents to seek treatment for some medical concerns, such as sexually transmitted diseases, mental health services, drug and alcohol dependency, pregnancy, and contraceptive advice. These adolescents can seek medical treatment without parental permission in these situations. But what about parental rights to see the child's medical chart? Some states do allow unrestricted parental access to a child's chart, but a responsible practitioner should be available to answer any questions. You need to know what your state laws are. A child differs in anatomy and physiology as compared to the adult, so the child's illnesses, responses, and treatments may be different from an adult's. Children are not miniature adults, so it makes sense that the plan of care will differ. Recognizing developmental and growth delays will assist the nurse in formulating his or her plan of care, but it can also provide an opportunity for early intervention to prevent further developmental delays. Developmental needs will have an impact on a child's response to illness. They react dependent on their age, the amount of preparation given, their security of home life, previous hospitalizations, support of family and medical personnel, and their emotional health. Their reaction can be influenced by developmental age, parent maturity, culture, religious background, and state of health. So what are the needs of a hospitalized child? With an infant, the major goal is to assist parent-infant attachment process and promote the sensoromotor activities, provide liberal visiting hours, and expect infant frustration because the infant is not getting what he wants when he wants it, and the infant's schedules are all disrupted. With a toddler and young children, we need to expect clinging and regressive behaviors. The goal is to provide individualized care according to the child's development and diagnosis. Incorporate home habits into care as much as possible. Use play to help soothe. Understand the toddler's world revolves around the parents. Understand that crying is a healthy outlet. We wait to forewarn the child about unpleasant or new experiences until immediately before they happen. And if restraints are necessary, we need to provide increased emotional support. With a preschooler, these children have magical thinking and fantasy. This is normal. They fear bodily harm. Make certain that treatments and procedures are explained clearly on the child's level. They may be irritable or demanding. With school age, they're at the industry and independent stage. They can participate in some of their care and they can make some simple choices. It's very common for this age to be brave and show little emotion. With the adolescent, they do experience a loss of control. They can be withdrawn, non-compliant, or angry. They can be concerned with their appearance. We need to allow choices, privacy, and peer visitors for adolescents. Adolescents often do well with a roommate as long as the roommate is not senile or an infant. And parents' needs. They can believe that they are to blame. They may have neglected immunizations, they feel guilty, helpless, or anxious. We need to encourage the parent to help participate in the care of the child, and remember that communication will help decrease fear. As for some safety tips, make sure that we keep crib sides up when one is in use. Do not force feed children. Identify children with bracelets. Use a bubble top or plastic top on cribs if a child is a climber. Make sure that cribs are placed away from outlets and appliances. Keep medications out of reach. Use infection control practices with toys, etc. Don't allow equipment to be used as toys. Do not ever leave young children unattended. And do not prop bottles. When preparing for procedures, you need to choose your battles. If allowing a child some control, like hanging on to a special toy in isolation, taking or wearing an item to a procedure or surgery, etc., helps the child in dealing with the stress of a situation, then allow it. Remember to keep the explanation of the procedure to the child simple. Use pictures or appropriate language levels. With infants, make sure that parents are involved. Include those familiar objects. Soothe and distract as necessary. Toddlers and preschoolers, again, involve the parents. Give permission for the child to cry. Allow choices when possible. Use distraction. Soothe as necessary. And involve play as appropriate. Sometimes allowing the child to play with the stethoscope or the blood pressure cuff is perfectly normal prior to using it on the child. School age, all of the previous interventions that I've mentioned, but also again allow the child to examine the equipment and encourage them to verbalize their fears. You can also offer small rewards after treatment and procedure, and this would also work very good with toddlers and preschoolers. With adolescents, be sure that you provide privacy and involve them in the treatment and procedure. Of course, explain the treatment and procedure and suggest ways to cope. In the performance of procedures, be non-threatening. Provide soothers, toys, pacifiers, stroking, cuddling, etc. Use topical analgesics as applicable. Keep frightening objects out of view. Explain in appropriate level terms and word associations. For example, when giving a blood pressure, you can say that you're going to give the arm a hug. Allow children, again, to explore the equipment as applicable. For example, allowing them to listen to their own heartbeat. Remember, it is okay if a child yells or cries, and make sure that you restrain them appropriately to provide for safety. If restraint, make sure that you choose the appropriate style of restraint. This is a variety of different restraint methods. You have the mummy or swaddling restraint at the top left, the papoose board or a type of papoose board. Sometimes the mummy restraint is referred to that. This is the circumcision board that is used when infants are circumcised, the mitten, and various other restraints. Again, make sure restraints are applied appropriately and not too tight. This is how you obtain urine specimens from an infant. These are called U bags or urine bags, and they have adhesive that is applied to the skin around the perineum. Nasal cannula and prongs for children can provide up to 50% concentration of oxygen. We usually do use humidification when we're providing oxygen to children. A plastic hood for infants is another method of providing oxygen. It allows the oxygen to be blown around in the hood instead of the infant's face. The oxygen tent concentration is difficult to control and maintain above 50%. You've got to keep it closed because it does provide a humidified mist. The child can be removed for feedings and bathing at times, but they need to be kept in the tent as much as possible. Minimize opening it. Keep it tucked in at the bottom. Flush the oxygen after it's been open for a long period of time. Make sure that you check the temperature. It's humidified. It can get damp and wet in there. It can get cold, but then it can also get too hot. Keep the child warm and dry, and allow them to feel secure by putting a favorite toy in there. But I would not recommend putting a stuffed toy because, again, things get damp inside this tent. You can use pulse oximetry and an SaO2 to monitor effectiveness by using it on the finger, toe, hand, or ear. Familiar rituals and routines should be incorporated into the plan of care when possible. Avoid directly criticizing traditional health cultural beliefs and practices as wrong or harmful, or implying that biomedical measures are uniformly correct and effective and the only way to prevent an illness or treat sickness. Various cultures that may be seen with children in health care include poverty, homeless, migrant families, and immigrant families. Characteristics of children who live in poverty: they may have insufficient clothing, poor sanitation, poor nutrition, or a lack of healthcare resources. The migrant farm workers: these children may have a lack of social skills or education. They have inadequate sanitation and, again, a lack of healthcare resources. In immigrant children, issues can include depression, grief, anxiety, and separation. We need to respect different cultures. Cultural sensitivity decreases anxiety and improves compliance. Cultural resources should include brief descriptions of the culture and views on health, illness, diet, and other matters. You can find these on the internet. How a disease or condition is viewed varies by culture. The nurse should make themselves aware of any specific attitudes. And don't forget to utilize your coworkers. There's usually many different cultures within a healthcare facility. Ask. Those who understand their own cultural beliefs are going to be more sensitive to the cultural needs of others. Culture can include a language barrier, and some cultures view eye contact as rude. So again, make sure you know what each culture believes. Watch nonverbal cue and body language. If you think things are going well, but nonverbal cues and body language tell you different, then you need to reevaluate. Remember that what is seen as abnormal behavior may only be a cultural characteristic. Be open to be taught and learn from others. In communication, be sensitive to cultural views on personal space, smiling, eye contact, touch, and focus. With religion, it can dictate a family's code of morality, education, male and female roles, and the selection of a mate. Make certain that you assess any special religious considerations and be supportive. Children may use an indirect approach to communicate their need for spiritual support. Some religious considerations are dietary restrictions, baptism, rituals, and need for clergy. The battered child syndrome is abuse of children by parents or other caregivers. It can be physical, sexual, nutritional, or emotional, and it can occur at any age. Different types of abuse and neglect include child neglect, which is the failure of a care provider to provide for the child's basic needs and adequate level of care. It is the most common form of maltreatment or abuse. Approximately 63% of these cases are related to deprivation of necessities. Excuse me. It accounts for 1,560 of childhood deaths in 2010. It can be due to a lack of knowledge, a lack of education, a lack of resources, and often caretaker substance abuse. Two types of neglect would be physical neglect, which is a lack of necessities such as food, clothing, shelter, supervision, medical care, and education, and emotional neglect, which is a failure to meet the child's need for affection, attention, and emotional nurture. Emotional abuse is the deliberate attempt to destroy or impair a child's self-esteem or competence. Different forms of emotional abuse include rejection, isolation, terrorizing, ignoring, corrupting, verbally assaulting, or overpressuring the child. Physical abuse is the deliberate infliction of physical injury on a child. There is no universally accepted definition of physical abuse. Each state will define abuse according to its individual reporting laws for the legal definition. Remember, you are a required reporter, a mandated reporter. It is reporting that is required when you have reason to suspect that a child has been harmed as a result of physical, mental, or emotional abuse or neglect or sexual abuse. And this is obtained from the Kansas statutes for mandatory reporters. The shaken baby syndrome is caused from the violent shaking of the infant or a young child, and it causes the brain to rotate and bang up against the sides of the skull. Signs and symptoms are vomiting, unresponsiveness, irritability, poor feeding, seizures, posturing, altered LOC, level of consciousness, apnea, bradycardia, or death. Long-term effects can be seizure disorder. The Munchausen syndrome by proxy is an illness that one person fabricates or induces in another person. Now, understand that in some adults this can be themselves. It's not necessarily another person. But with children, it's usually a parent fabricating signs and symptoms of an illness in the child, who is the proxy, to gain attention for herself. Examples would be seizure, vomiting, sleep disorders, and respiratory distress. With sexual abuse, it is the use, persuasion, or coercion of any child to engage in sexually explicit conduct. There are several different types of sexual abuse. We have molestation, which is the touching, fondling, kissing, single or mutual masturbation, or oral genital contact. Incest is sexual activity between family members such as step-parents or siblings, grandparents, uncles, aunts, parents, or siblings. Exhibitionism is an adult that exposes a child's genitalia to other children or adults. Child pornography is arranging and photographing sexual acts involving children. child prostitution, selling children for sexual acts for profit, and pedophilia is an adult that has a preference for prepubertal children as a way to gain sexual excitement. There's specific characteristics of abused or neglected children. They are often from an unplanned pregnancy. Many of them were premature or had a low birth weight or major birth defects. The child might be hyperactive or brain damaged. The children often come from homes of divorce, poverty, unemployment, poor housing, frequent relocation, alcoholism, and drug addiction. They sometimes resemble a person that the parent dislikes. Characteristics of an abuser. Most commonly, the parents were abused themselves as children. They are oftentimes substance abusers of one or more substances. They may currently suffer from or have suffered from in the past emotional problems. The abuse is usually done by one parent, but the other parent is often aware and they just don't do anything about it. The parents often have a very high expectation of their child. If the child doesn't perform up to expectations, then they're punished. Abuse can occur at all socioeconomic levels. How do you identify the abused child? Well, first of all, you look for scars, bruises, and injuries. Injuries that are not consistent with the explanation that's given, or history that's inconsistent with the child's developmental level. Markings generally characteristic of abuse. Old bone fractures that are seen on x-rays or are in different stages of healing. A complaint other than signs and symptoms of abuse. When the child comes in with a complaint of the flu and they obviously have first and second degree burns. Signs of physical neglect such as malnourishment, improper or dirty clothing, previous reports of abuse in the family along with repeated visits to the emergency room. Parents' explanations for injuries that are inconsistent. The story keeps changing. And the child withdraws when approached by the parents, the nurse, or the healthcare provider. How do you intervene in these situations? Well, with the interview, you need to get the history of the incident and document it carefully. Don't lead the child, but allow the child to explain at their own pace. Self-control is needed for nurses. It's normal to be angry toward the parent, but you need to be aware of your own emotions to be able to work effectively for the child. Make sure that you perform a thorough head-to-toe examination after the rapid initial assessment of airway, breathing, circulation, and neurological systems. Document locations with detailed descriptions, color, size, location of bruising, etc. Burns. Note the location, the pattern, any eschar or blisters. Use diagrams of the body to assist with more accurate documentation. We also need to provide emotional care by providing a safe environment, explaining all procedures, providing toys and familiar belongings. Provide physical cuddling and holding when it's appropriate. And when you're talking with an abused child, if the child reveals abuse, provide privacy. Never promise not to tell because you are required by law to report abuse. Always maintain that caring attitude. Use the child's vocabulary. Don't use those leading statements because you can distort their thinking. Reassure them that they've done the right thing by telling about the abuse. Tell them that the abuse is not their fault. The child is not to blame. And keep the child informed about what's going to happen now. And if you need to stay with them, do so, because they're probably scared. Morbidity is the prevalence of a specific illness in the population at a particular time. Mortality is the total number of individuals who have died over a specific time period. Infancy Accidents are going to be the major cause of death in infants, especially in the 6 to 12 month age range. Leading causes include suffocation, motor vehicle, ingestion or aspiration. They're at increased risk for injury related to increasing locomotor and manipulative skills, their insatiable curiosity about their environment, and the way they explore through taste and touch. Accidents in early childhood. Motor vehicle accidents are the most common cause of childhood deaths over the age of 1 year. Leading causes include, again, motor vehicle accidents, but drowning, fires, and burns. Make sure that the child, when they're in the car seat, is in the car seat and properly restrained. Making sure that airbags are off if the child is in the front seat, putting the child in the back seat when at all possible. Middle childhood injuries. These children are ages 5 to 14. Motor vehicle accidents, again, are the most common form of severe injury and death, both in passenger and pedestrian. So accidents for this age range are motor vehicle accidents, drowning, fires, and burns, but they also have a risk of strains, sprains, and fractures due to the increased activity of their age. Bicycles, ATVs, skating devices cause a large number of head traumas. Trampoline injuries are the highest among children who are aged 5 to 14. Bicycle injuries put children ages 5 to 9 at the greatest risk for injury. Make sure they wear helmets and follow safety rules. Emphasize 3 vehicle safety measures in vehicles. There's the effective restraints, appropriate seating in the vehicle, and effective door lock mechanisms. With adolescents, the most vulnerable ages are 15 to 18. They have increased risk-taking behavior in combination with feelings of indestructibility. They're at an increased risk related to peak physical, sensory, and psychomotor functioning, which gives teenagers a feeling of strength and confidence. They have that immortality complex. Leading causes of injuries are motor vehicle accidents, poisoning, drowning. There's an increased rate of non-automotive vehicle accidents with ATVs, jet skis, snowmobiles, and sports injuries are definitely increasing for this age group. Car seats are designed as infant-only or infant-toddler models. The seat must be semi-reclined when it faces the rear of the car. Excuse me. The car seat must be anchored to the vehicle by a seat belt of a latch system, and the restraint has a harness system for securing infants. Make sure that the parents are following manufacturer instructions. And yes, we have to talk about end-of-life care when we're discussing pediatric nursing. Not all pediatrics survive to adulthood. Again, we have palliative care, also known as comfort care, which is the active total care of patients whose disease is not responsive to curative treatment. The environment can be the hospital if the family chooses or the condition is too unstable to return home. It can be at home if the child is stable enough to return home with periodic nursing visits. It can be in a hospice, community healthcare organization that specializes in the care of dying patients by combining the hospice philosophy with the principles of palliative care. Hospice care for children began in the 1970s. We have to remember that death is a natural process, and it can include physical, psychological, social, and spiritual needs for the patient and family. Common fears that are faced excuse me, by the dying child and family. We have the fear of pain and suffering. With the parents, it results in feelings of helplessness and they feel like they have to be present at all times. With the child, it causes a lack of quality of life. Opioids can relax respiratory muscles to make it easier to breathe. Scopolamine can reduce secretions and the noise of secretions as it moves across vocal cords. Pain control has to be given the highest priority because many children are under-medicated. Most children will experience some amount of pain in the terminal phase. With a child, there is a fear of dying alone or for the parent of not being present when the child dies, and this can be exhausting for the family members and the patient. There's the fear of actual death. What occurs to the child through the death process? Well, the child's going to become less alert. They will lose sensation in lower extremities. They may have a sensation of heat, but they feel cold to the touch. They may be sensitive to light, confused, have a loss of bowel and bladder, difficulty swallowing, decreased appetite, change in respiratory pattern, and you may hear that death rattle. This can be the most distressing to the family, but reassure the parents that it's not distressing to the dying child. Make sure that you provide education to the parents and siblings. Family members often start death vigils, and this does lead to exhaustion. Help the family arrange a shift of present members to allow rest for others. Encourage volunteers. Parents should be allowed at the bedside as much as desired in the hospital, and make sure that you help attend to the parents' needs for comfort, food, blankets, toiletries, etc., and help field phone calls, take notes, or log phone calls. For the dying child, there's no greater comfort than the security and closeness of a parent. But many families choose to have the child die at home, although they can be readmitted to the hospital at any time. Grieving begins at the time of diagnosis of the chronic or terminal illness, at the loss of normal life. The physical process can be distressing to parents and siblings. You need to provide the family with expectations of dying. If the child's at home, nursing care visits can be longer to provide that additional support. We look at anticipatory grief. This is when the death is an expected or potential outcome, and there's specific behavioral reactions that we can expect to happen. These can include denial, anger, depression, or somatic signs and symptoms such as a tight throat, choking, shortness of breath, sighing, or a lack of muscular power. So when the child dies, stay with the family and sit quietly if they prefer not to talk. Cry with them if they desire. Don't be judgmental about grief reactions. Don't rationalize the child's death with the statement of, "Your child is not suffering anymore." And avoid artificial consolation, such as, "I know how you feel." Deal openly with feelings such as guilt, loss, anger, and self-esteem, and focus on feelings with the use of feeling word statements such as, "You're still feeling the pain of losing a child." And refer the family for appropriate self-help group or professional help as indicated. Acute grief begins within hours to days of death, whether it's unexpected or expected. They may have psychological or somatic symptoms. There may be preoccupation with the image of the deceased, feelings of guilt or hostility, and a loss of usual patterns of conduct. We need to provide guidance to the bereaved because these are normal reactions. It is necessary for them to face resolution of the loss, and they have to do this before they can begin to restructure a meaningful role in society. There's a period of adjustment. There's an eventual attachment to new people, a development of new interests over time, Resolution of grief can take years. There's an intensification of grief possible in early years of grief work. This helps families recognize normalcy of adjustment to feelings and behaviors because this does help with the grief process. Understand that mourning takes time. Acute grief can last for weeks or months. Resolving loss can take years. Holidays are going to be very difficult, and previous support people can now expect a family to adjust because, enough time has passed, and then mourning becomes very lonely. So how do children react to death? Toddlers really don't have an understanding. They continue to act as if that person is still alive. They might have separation anxiety and fear of being away from the person who dies. Preschoolers, they don't feel that death is permanent. It doesn't apply to them. They can demonstrate curiosity about death of other humans, animals, or plants. They have that magical thinking. Bad thoughts might come true, or they might think of it as a punishment. They view death as being reversible. Their greatest fear of death is separation from their parents. With a school-aged child, they do understand that death is permanent and final. They believe that they might die, but it's going to be in the very distant future. They begin to understand that death is universal and fear that their parents will die someday. They do have fears of a painful death, and they associate doing a bad deed or thought with that being the cause of the death, and so they feel intense guilt. The adolescent is able to logically understand death, that it's universal and permanent. They may have a fear of disfigurement and isolation from their peers. They have this complex of feeling invincible, that death will not happen to me, so it's often linked to risky behaviors. But adolescents are the ones that have the most difficult time in coping with death.